Today in this explainer, we're diving into the absolute mechanical marvel that is the human hip joint. We're going to trace the complete patient journey of developmental dysplasia of the hip, or DDH, by mastering how this joint develops and, well, how it sometimes fails to develop. We literally have the power to alter the trajectory of a child's life. It's a fantastic puzzle, really. Okay, let's dive into this. Here is our clinical pathway for today. First, understanding DDH. Second, identifying risk factors. Third, the clinical examination. Fourth, radiographic evaluation. And finally, treatment and management.
Section 1. Understanding DDH. Now, you might be wondering why the medical community shifted away from calling this congenital hip dislocation. Well, the reason is actually profound. You see, this condition isn't always detectable right at birth. The term developmental is vastly more accurate because, honestly, we're looking at a whole spectrum of hip instability here. The hip might simply be dysplastic, meaning the acetabulum, the socket, is just underdeveloped. Or it might be subluxated, where the femoral head is kind of in partial contact but off-center. Or it could be frankly dislocated, completely outside the socket. It's a moving target, Nicola. It literally develops over time.
So the crucial point is distinguishing between typical and atypical presentations. Typical DDH, which accounts for roughly 90% of cases, happens in an otherwise completely normal infant and can develop perinatally or postnatally. But then, on the flip side, we have teratologic or atypical DDH, making up the remaining 10%. These dislocations occur deeply in utero, and frankly, they're fundamentally different. They're totally unreducible on a neonatal exam and are commonly associated with other underlying syndromes like myelomeningeo or arthrogryposis.
Section 2. Identifying risk factors. Take a look at this list, Nicola. Notice a common theme among these major risk factors? It's intrauterine crowding. First pregnancies, or primiparity, feature a tighter uterus. Oligohydramnios means low amniotic fluid, which restricts movement. High birth weight, over 4,000 grams, physically limits space. And then there are postnatal cultural practices. Swaddling an infant with their hips tightly bound in extension, that is a massive, massive mechanical risk factor for disrupting proper hip development. The hip joint absolutely craves flexion and abduction to form perfectly. But of all the data, this number is perhaps the most staggering. Typical DDH occurs in females at a ratio of 6:1 compared to males, 6:1. Why? Well, it's largely due to maternal relaxin hormones affecting female infants much more profoundly, leading to greater ligamentous laxity. To put that into perspective, if you have a firstborn female infant who presents in the breech position, she sits in the absolute highest risk category. We're talking a striking 8% chance of having DDH. Section 3. The clinical examination. To systematically screen for DDH, we use a beautifully simple rule of 3 for our clinical examination. These are 3 highly specific, targeted mechanical tests: the Barlow maneuver, the Ortolani sign, and the Galeazzi sign. Let's put on our clinician hats and examine how each of these actually works in practice. First up is the Barlow maneuver. Think of this as a provocative stress test. The infant's hip is currently resting in the socket. You flex the hip and gently adduct it, bringing it right toward the midline while applying a downward posterior pressure. What we're really testing here is instability. Can the hip be pushed out of the acetabulum? If you feel it slip out, you've got a positive Barlow maneuver. It tells us the joint is dangerously lax. And this brilliantly illustrates the counterpart to Barlow, the Ortolani sign. If Barlow pushes the hip out, well, Ortolani puts it back in. You take that dislocated hip, abduct it away from the midline, and lift the thigh forward. If the hip reduces back into the socket, you're going to feel a distinct, palpable clunk. But a word of caution here. You must be incredibly careful as a clinician. Do not confuse this profound clunk with benign, high-pitched ligamentous clicks, which are totally normal in infants. We are feeling for the actual mechanical reduction of the joint. Now, as maternal hormonal laxity fades over the first few months, those Barlow and Ortolani tests become, quite honestly, much less effective. By 2 to 3 months of age, stiffness and apparent limb shortening take over, and this is exactly where the Galeazzi sign becomes vital. Place the infant completely supine on the table, flex both hips and knees to 90 degrees, and just look at the knee height. If one knee is distinctly lower than the other, boom, it indicates the femoral head on that side has migrated upwards and posteriorly right out of the socket. Section 4. Radiographic evaluation. You see, Nicola, you can't simply X-ray a newborn hip and expect a clear picture. Why?
Because the infant hip is primarily cartilage, which is radiolucent. It just doesn't show up on an x-ray. So for infants under 4 to 5 months, ultrasound is our gold standard. We measure the alpha angle, representing the hard, bony roof, which should be greater than 60 degrees, and the beta angle. However, once the child hits that 4 to 5 month mark, the ossific nucleus of the femoral head finally appears. At that point, we transition entirely to standard radiographs. Now, what's really interesting about this slide is the architectural grid drawn on these pelvic x-rays. It's like a giant puzzle. We draw Hilgen-Reiner's line horizontally through the triradiate cartilages, then Perkins' line drops vertically down from the lateral acetabular margin. Ideally, the femoral head should sit perfectly right in that lower, inner quadrant. But look at the right side of the abnormal hip. The femoral head has completely drifted up and out. You can also see Shenton's line, that sweeping arc along the inferior femoral neck and the superior pubic ramus. On a dislocated hip, that beautiful arc is broken. We also measure the acetabular index. An angle over 25 degrees here just screams dysplasia.
Section 5. Treatment and Management.
Let's move to and see how this builds into a distinct timeline. The rule of thumb here: early intervention is drastically less invasive and incredibly effective. From 0 to 6 months, we rely on the dynamic Pavlik harness. From 6 to 18 months, we step things up to a closed reduction under anesthesia, followed by a spica cast. And for children diagnosed even later, or where earlier treatments just didn't work, we must resort to highly invasive surgical osteotomies to physically reconstruct the bone geometry.
Let's examine our first-line treatment, the Pavlik harness. This isn't just some rigid cast, no, it's a dynamic splint. It maintains the hips in about 100 degrees of flexion and a very gentle 45 degrees of abduction. By holding the femoral head concentrically within the dysplastic socket, we literally stimulate the cartilage to grow and deepen naturally. It boasts a staggering 90% success rate. But precision is absolutely crucial here. You must avoid forcing the hips into extreme abduction, because that cuts off the delicate blood supply and causes a devastating complication known as avascular necrosis, or osteonecrosis.
Now, if the harness fails, or if the child is between 6 and 18 months and physically just too large and strong for it, we have to move to a closed reduction and spica casting. This requires some very careful calculus by the surgeon in the OR. They map out the stable zone, which is the range of motion where the hip actually stays in the socket. Then they calculate the safe zone, narrowing those limits by about 15 degrees to ensure they aren't stretching those blood vessels too tight. Once placed in the cast, right within that sweet spot, the reduction is perfectly confirmed by an arthrogram or CT scan, and the child is immobilized for 3 to 4 solid months to let the anatomy solidify.
Finally, for the older child, that magic window for natural cartilage molding has basically closed. Soft tissues and bones have already adapted to the dislocated state, so simply pushing the hip back into place, yeah, that won't work anymore. We have to perform surgical interventions, specifically femoral shortening or derotational osteotomies, or pelvic osteotomies to physically redirect the socket right over the femoral head. It is a major anatomical realignment. We're literally racing against the clock here, as the predictability of the hip naturally remodeling itself drops off sharply after the age of 4 and becomes highly, highly unpredictable after age 8. So, Nicola, I leave you and our viewers with this final thought to ponder. We know for a fact that early clinical screening, combined with a simple Pavlik harness in the first few months of life, can seamlessly cure this condition 90% of the time. But what if we miss that critical early window? If we fail to perform those Barlow and Orvolani maneuvers properly, well, we condemn that child to a permanently subluxed hip, marked gait deviations, early onset osteoarthritis, and the terribly high likelihood of needing total hip replacements as a young adult. Early vigilance is absolutely everything in preventing a lifetime of orthopedic disaster. Keep your eyes sharp and your mind engaged.